Hello, everyone. Thanks for taking the time to join us with today's webinar. This is Amy. And for today, we'll have a webinar lectured by our speaker, Dr. Samia Hanna. And for today's webinar, it will take around 1 hour. And if you have any questions, you can write in the comment section. The speaker will answer the question for you. Now let's get started and welcome the speaker, Dr. Samia.
Thank you very much, Amy. How are you? Hope everything's fine. Hi, guys. I'm happy to be here together today with you. It's a very nice topic, and I hope that by the end of this lecture that you will have a good understanding of the topic. And please feel free to send me messages and questions whenever you have them, and I'll do my best to answer all of them at the very end of the lecture. Let me first introduce myself to you. So my name is Dr. 𝗙𝗵 Hanna. I'm a senior lecturer at COMD Ulster University in the UK. I'm a European Society of Endodontology certified member, and I'm an endodontist and practice owner at 𝗙𝗵𝗽𝗂𝗏 Dental Clinics in Cairo. I did my bachelor degree in Egypt and in Spain, and then I did my master's in the UK, later on followed by the PhD in Spain. And then I did postgraduate studies and fellowship of higher education in the clinical education in Edinburgh later on. So I hope this will be a good lecture together. And just to give you a little bit of insights, this is the university where we teach in the UK, Ulster University and College of Medicine and Dentistry. Those are the places where we usually give our webinar, our lectures. And this is also a small insight into my clinic, where it's in Cairo, Egypt, where we practice all different fields of dentistry, specifically also into root canal specialty. So let us go and look at this periapical X-ray. Let us take a few seconds just thinking about this X-ray. We can trace 4 canals cleaned and shaped, maybe cleaned and shaped, not that much, but yeah, but it looks up to the lens. We can see maybe a small fragment of separated instrument in the mesial canal, another one in the apical side. We can see the coronal restoration that has a huge void inside in the coronal 1/3 of the pulp chamber. We can see periapical lesion in the mesial root, which looks to be intensified, and another one in the distal root. Whenever I saw one of those X-rays, I always say that someone sat down, opened those tooth, and did everything they were taught, and this is what happened. So if you talk with all dentists all over the world, never ever one of them will tell you, I'm opening a tooth to make it fail or to try to fail it. Everyone is trying to do their best, from the GPs to the specialists to all different specialty. They have a little bit of information. Depending on the level of information and level of expertise, this is the outcome that goes out. So the intention that most of the people will be trying to do their best. So this lecture today is going to be about the understanding of what happened in something like those cases, why it did happen, and how to prevent it or what to do instead. So does shaping failure cost us? Definitely. So I always say we have 3 pillars of the triangle. So we have the clinical cost, we have the patient cost that the patient had to endure, and we have the clinician cost that the doctor or the specialist or the GP had to endure. So from the clinical point of view, we can see that shaping failure can lead, whether it was because of miscanals, residual bacteria, it will lead to residual bacteria, reinfections, and this we see all the time, especially in something like upper molars where the MB2 is missed, upper 7s where the distal canal is always missed, depending on the tooth. A lot of times we have specific missed anatomy in them. And then we can see for the patient cost that the shaping failure will lead to higher cost for the patient, going through from the initial treatment, then persistent pain and swelling, different visits to the dentist, and then maybe retreatment and more appointments, more pain, swelling, and then maybe sometimes extraction risk, implant placement, and it's a full sequela of cost and money and time burden over the patient. And not just the patient that's going to be affected, but the clinician also, because when we have to stay more time in specific cases, we lose more time to treat other patients. We lose more confidence in our abilities to treat and get a good outcome. And later on, by time our reputation within the community will get affected, that our treatment is not as good as it should. From the literature point of view, we have a study, or actually the guidelines by Patel in the 𝗙𝗍cie in 2006. We can see that a UK-based study found that procedural complications such as file separation, perforation, and missed canals were among the top 3 reasons GDPs, the general dentist, refer to specialists. So we all get afraid of such things, and all GPs get afraid of such things, and then they send them to the patient, to the specialists. Also, GPs on average, they refer 46% of the patients who need to root canal to endodontist. This is in the UK. And actually, it's a good number, because if we look at the complexity of the root canal system, I think we all agree that more than 50, 60, 70% of the cases have some kind of complexity, whether curved roots, number of canals, accessibility, patient management, not from different aspects for complexity. So it's good that GPs can have their back and they send to specialists. Also, we can see that separation rates of a separated instrument, it happened between 0.25 to 6%, depending on the operator experience and the canal anatomy. And this was in Journal of Endodontics 2006. And actually, if you look at it, it's a good and big number. So in every 100 case, if you treat like 50 or 40 cases per month, so every couple of months you have 6 cases of fractured instrument. That's a big number. So there will have to be a way where we can find and decrease this number from 6 to 0.25. The list of failures in endodontics are big. And in order to look at them all in the same lecture, that will be a little bit hard. But today we are going to concentrate about 4 specific failures, okay? And this table, it's called Eisenhower matrix, or like 2x2 matrix table. This is very good in explaining like the high probability, the probability versus the stage of occurrence of each of those failures. So first, for example, we have the ledge formation. This is the higher probability and the early stage of occurrence. And then we go later on to the different other failures. So we have the ledge formation. This can happen very easy at the very start of the preparation. We have the transportation or zipping that can happen during the cleaning and shaping. We have the file separation that can happen whether because of such reasons or others that we'll be talking about in a little bit. And then we have the under or over preparation that can happen while cleaning and shaping our canals. But the one thing that they have in common, that if somehow I was able to do a ledge, then higher probability I will have a transportation. And with this high ledge and transportation, there is a high probability of having file separation. So sometimes it's just a sequela of events that happen within the specific tooth, and it's not just an isolated event. If we concentrate a little bit on the ledge formation is defined as the creation of an artificial step or deviation on the root canal wall that obstructs the instrumentation from following the original path. So how do you usually see it? Suddenly, while working or while cleaning and shaping, we find a ledge, we find a resistance for our file to go in. We don't know what happened. We thought it's maybe apical plug or like a few debris, dentine mud in the apical side. We try to go a little bit harder and harder, pushing harder to get this done, and then things will get suddenly in a different direction. The primary causes of this ledge formation are the rigid file, for example, entering a rigid file in a curved canal, no pre-curving for manual files or even some of the rotary files, and then also skipping the glide path step. It happens up to 22% in curved canals, without having a good glide path. This was by Paquet et al. So it's a high probability in curved canals, especially if we don't get a good glide path. In order to explain it easier, we can see that the flexible file on your left hand side follows the canal, follows the curvature of the canal smoothly, while the rigid file, when it was going in, it just hit the wall and started to dig within the dentine and form the ledge. And this is where we say that the file forced the outer wall of the canal and caused ledge formation, and that the canal had to follow the file, not the file follows the canal. And as we said in a little bit, that ledge formation is a gateway failure. It creates the conditions for everything else on this list to be achieved. Other type of failure is the transportation or zipping. I guess we all know what are the differences between transportation and zipping. Transportation is just the apical foramen is transported into another area, while the zipping is that, for example, the elliptical distortion of the at the apex from the file tip action. So let's say if the file tip, the apex is a circular outing, then the file will continue making it in a different elliptical way, or changing the dimension or changing the geometry of it. The consequences of such transportation or zipping is that I will have a poor apical seal, as all our GPs are cone-fitted similar to our files. So when we put them in, we do not really seal the rest of the canal. We can have a perforation risk. When we have transportation, we are thinning the dentine wall, and this will cause a perforation risk. And irrigation bypass, as the apical constriction is destroyed, then later on we can have the irrigants passing through there. Its incidence, again, it has a high percentage. Without a good glide path, the incidence of transportation is around 30%. The file not following the canal is being forced to follow the file, exactly as we were just saying, that the canal that I had to transport into different dimension to be able to follow the file that I'm introducing. In this case, in this micro-CT study by Marciano et al. In 2012, imagine that the red color is the original canal and original state of the canal before the preparation. And then the green is the areas cleaned by endodontic instrument. Imagine, like, if we look at this, if we look at the apical side, if we look at the effect of our instruments, if we looked at the amount of walls that wasn't touched, if we looked at the amount of remnants of dentine remnants that wasn't cleaned, we can see that we create transportation, we create ledging, we create all of this kind of stuff with our instruments, if not choosing correctly. And then we go to the file separation, the one the clinicians fear most. How many times you had the file separated? I think all of us, if we work enough, we will have a good answer for that. And how many of those times we weren't sure why? So sometimes we just do everything right, like, having a good glide path, we introduce a file in the correct way, correct sequence and everything, and then we have a broken file. This is usually like depressing, and it destroys our courage and confidence. But again, it has a way to understand. So as we said, this incidence is around 0.25 to 6%, and there are two different distinct mechanisms that can cause the file to separate, whether it's cyclic fatigue or torsional failure. So the cyclic fatigue is when there is a curvature, the file continues rotating within this curvature, the metal gets fatigued, and then the file gets separated. We say that this is easier to retreat, as the file wasn't really bind to a specific area, or wasn't really hard to like, didn't rest in the dentine in a hard way. However, the torsional failure, this is when the tip of the file gets stuck in one point in the canal, and then the shaft continue to rotate, and then this will happen that the file will twist off. This is definitely harder to retrieve or harder to bypass as the file already blocked this part, and in order to make the file unblock or unbind in this area is sometimes it's a little bit harder. And then we go for the under or over preparation. So which one do you think is safer? I think all of us will agree that within our education, especially the very basic education, we always thought that over preparation, maybe it makes more sense because at least the canal is cleaned, no problems in that. Maybe the under preparation we still have bacteria and we still have pulpal tissue that will cause later on the problem. However, I think this thought is completely wrong because whether it's under or over, both of them compromise the biological outcome equally. Both of them have different ways of affecting the failure of the teeth. Whether under preparation, this is where inadequate disinfecting zone, debris was packed in this area, missed isthmuses, missed cleaning, and this will cause definitely the failure. Or with over preparation, this is where the dentinal wall got thinning very much. This is where strip perforation risk increase and the apical constriction will be destroyed, which will lead to debris getting out of the root, irritation to the periapical area. Maybe sodium hypochlorite also will get out of will be extruded from the canal, causing more irritation and more problems. So we cannot really think doing an accident in hitting a car or hitting a truck is better because both of them are an accident. so let's try not to think this way, and let's try to do everything possible to reach the correct lens. The evidence also clearly state that the bigger is not the better. So a lot of times they say when we look at X-ray, if the GPs looks very thin, it's defective, it's not big enough. So does this mean it's failure or no? Well, the literature definitely disagree with that. That Patel et al. In 2013 agreed that preserving as much tooth structure as possible while achieving adequate disinfection is the goal to go. 𝗙𝗵𝗃𝗧 and all his papers regarding the cleaning, the irrigation dynamics and everything said that irrigants depend really more about the needle placement and activation rather than the canal diameter. So even if I have a big canal and then I introduce the irrigation tip up to 1 millimeter from the coronal 1/3, then definitely I will not be cleaning anything. However, if I have a good sized canal with the correct placement of my needle, I will have way better disinfection. And then 𝗙𝗍 in 2010 agreed that mechanical enlargement has a ceiling effect on cleanliness, and that means that if, for example, we reach up to 2504 or 25 whatever or 3004, depending on the case, this is the maximum we can clean by files, but the rest we have to rely more on irrigation. But then why failure still happens? So we talked about the different types of failure. We talked about a little bit about why it can happen, but again, we have to concentrate a little bit on the whole intersection of failures. So in order for a failure to happen, it can has one of the three or two or three of them reasons for it to happen. So first we have the anatomy that includes whether there is curvatures, calcification, dilateration, accessory canals, hard anatomy, hard configuration, or missed canal, or whatever, all those kind of anatomy challenges that increase the risk of failure. And then if we go for the system, we have the file design, metallurgy, what this file, what was made of, kinematics, how this file moves, rotational reciprocation, whatever, the settings of the file, whether we are using the settings or no, all of these factors affect the failure rate and how we approach it. And then the protocol of my treatment itself, what are my steps? Am I following a protocol or I'm just working like this? Do I do good glide path, irrigation, sequence, discipline, or I'm just skipping files as to try to be quicker or something? So failure is really just a technique error. It's just a system anatomy mismatch. So sometimes we have the anatomy problem and protocol problem, and then this will cause the failure. Sometimes we have the anatomy problem and not a good selection of system. This will cause a failure, and vice versa. So it's a mix of all of those reasons. If we go to the system failure for the file, there are different areas where we can discuss, and we discussed them before, but today we'll just give a very quick look at them, that different parts in the file design when we are choosing the system that we want to work with affect the outcome of our treatment. First thing is cross-section. What is the cross-section that we're working with? Whether it's a rectangular, triangular, S shape, different cross sections were introduced. This will affect the cutting efficiency, will affect the debris removal, will affect the flexibility of the file, will affect the areas that's not touched with the canal. So all of these areas, all of this will affect the outcome of the treatment. Also the taper of the file. So our file taper, how it will affect the canal. Having to choose 0.2% taper, how well I'm going to clean the canal and how well I'm going to finalize my work. Having an aggressive taper like 0.8%, the amount of thinning that will happen to the dentinal walls, the amount of pressure, the amount of cracks that I'm introducing, all of this will continue to affect the treatment outcome. And then we have the tip design, whether it's a negotiating tip or aggressive tip, cutting tip or blunt tip. All of this, again, will affect the system that we're working in. I will affect the results of our treatment. And lastly, we'll have the metallurgy. Different wires were introduced in the market, lots and lots of talks from companies, lots of different colors, even blue, gold. It's very confusing, but again, we have to have a good understanding with every file that we're using. It has a different alloy, it has a different indication and contraindication. And sometimes using the blue treated alloy, which is sold as the best one, will have higher fatigue resistance, and but it will cause more other problem in a different area. So again, it's a full sequela of how to choose your file. It's not just one item. Every design decision in the file has a consequences in the canal. It's not just for marketing, it's not just for selling you a new stuff. And then we go for the glide path, which is still the most undervalued between clinicians. The glide path is always defined as a continuous smooth path from the orifice to terminus before any rotary use. Without it, all failures increase exponentially. That means that without the good glide path, I will start having ledge formation, transportation, or zipping. I will maybe have a separated instrument, and I will maybe end in under preparation or over preparation, depending. So in Journal of Endodontics, it was in 2009, 𝗏𝗏𝗏𝗏 said that on average, 60% reduction in the canal transportation when a glide path was established first. Again, Patino, in the same Journal of Endodontics, but in 2005, agreed that absence of glide path significantly increased file separation rate. And by CBCT-based study confirming canal centering is significantly when glide path is established. So even canal centering and the transportation, Kapper in 2014 established by his CBCT study that this canal centering is better 100% when glide path is established. So we always say it's 2 minutes that you're going to spend achieving a good glide path, but then it will save you the next 20 minutes, or it will save you from hours of retreatment or trying to bypass problems that you have made. How to reach this glide path? I always say that it's good to give a little bit of information about it in a quick way because this is very important. So for the coronal patency, we have to remove the pulp chamber roof completely, locate all orifice under magnification, irrigate with sodium hypochlorite before any file enters, and then a blocked orifice means a failed glide path before. So I have to see the full the full number of canals in a clear way so that when I introduce my file, it's going to be going smoothly. And also I have to create sodium hypochlorite to introduce sodium hypochlorite in this area so that it acts as a lubricant and facilitate my glide path reaching. And then we start with file 6 or file 8, K file in calcified canals or tight canals. Advance with then maybe a little bit of gentle watch winding motion, but never push the file not to create any kind of ledging. Pre-curve the file, it's a very important point, and then confirm the patency with the full working length. Once we reach there, then we go for our file 15 using watch winding motion. Once we have our file 15 going in smoothly to the working length, this is when we go back to our rotary machine and we continue with the glide path instrument and later on with the shaping. If I feel any resistance, stop, go back to the file 10, ensure your glide path, and then continue back to 15 and then rotary. For easier to remind them, to remember it, here's a quick way: glide. Always remember the word glide. So gain access, locate orifice, irrigate first, don't force files, and then enlarge progressively to file number 15. So always remember the word glide, and then you will remember the steps of how to achieve a good glide path. Irrigation. Most clinicians think of irrigation as a disinfection step. That evidence shows that it's equally as a shaping support system. So it's not just a disinfection step, it's a very equally important as shaping, equally important to prevent all of those four different failures. Irrigant penetrate only 1 to 3 millimeters beyond the needle tip. So this you have to concentrate and to remember always while introducing your needle inside the canal. Make sure you put them in a good and correct place. Also, 𝗙cie_𝗫 in 2008 proved that bacterial persistence is one of the primary causes of post-treatment diseases. And then Zender in 2006 agreed that debris packing block obturation in under-prepared canals. Volume and agitation matter more than concentration. So the fight was always between 1% sodium hypochlorite, 5% sodium hypochlorite, but again, the amount of irrigant introduced and the activation and the agitation is more important than the percentage of the sodium hypochlorite. A canal that cannot be shaped cannot be irrigated. A canal that cannot be irrigated will definitely fail. Always remember this. Always put it inside your treatment room. Just remember this extremely. Irrigation doesn't fail, but access fails. So irrigation itself doesn't fail, but access to bacteria, access to areas in the canal always is the reason for failure. But does irrigation only affect the disinfection, or it has an effect over the files that I'm using? Definitely, irrigation is contributing factor in the failure that we talked about. So unpacked debris compacts apically, which will later redirect the file forces and amplify the mechanical stresses, and this will result in the all four failures that we've talked about. So even not doing good irrigation will definitely cause mechanical instrument failure in the canal. So 𝗙cie_𝗫 in 2000 in Journal of Endodontics, debris accumulation causes torsional overload and identified as primary cause of in-use file deformation. So we always look at the complexity of the canal anatomy, and we say this is the cause for the separation of instrument or the file getting unwinded. But again, one of the big causes proven in the literature is the debris accumulation. Apical debris act as a physical obstruction that directs the file forces laterally, which cause the transportation. This was by 𝗙𝗏 in 2007. 𝗙𝗏 in 2007 also demonstrated that debris remaining from inadequate irrigation directly compromise canal shaping geometry, which will cause later on ledge formation. And Plotino G. et al. In 2009, Journal of Endodontics again, clinical conditions, debris, irrigant temperature, binding, all compound the mechanical stress on the file, which will cause the cyclic fatigue amplification, which might cause the separation of instrument. Again, the different concentrations of the of the irrigation affecting the metal of the alloy and the alloy of the file. If the file is not treated correctly, if it's not chosen right, then it will affect the file, maybe not from the first time of use, but second, third time of use, and this will cause the file to be weaker and higher probability of fracture. Just let me read this for you because I thought it summarized the whole thing about the debris packing and the hidden mechanical cascade. So when we don't irrigate adequately between file use, debris doesn't just sit there, it packs. And packed debris does three things simultaneously. It directs your file tip laterally, creating ledges of transportation. It binds your file rotational, accelerating torsional failure and fatigue, and it gives you false tactile feedback so you can't really tell when the preparation is actually complete. Inadequate irrigation doesn't just compromise disinfection, it actually creates every failure on the list as we discussed at the beginning of this lecture. So let us just go through those three cases in a quick way, not to lose a lot of time. And we see such case, lower first molar and lower the second premolar. We can look at the file. We see that there is the broken instrument in the mesial canal. So actually this case was referred to me as patient was between treatment, and then while his GP was working, those two separated instruments happened in the mesial canal and the patient was referred to me. So what do you think went wrong here? It looks like he started with a good coronal access, reached the canals, and then he introduced the file, and then he had the doctor had the GP had a broken instrument. Glide path problem, most probably didn't achieve a good glide path, introduced the file too early, and it got bind and it got fractured. Maybe also using the multi-use of the file. I know a lot of countries have the one single-use policy and rules, but other countries still use the same file for different cases, and this can also affect the outcome of the treatment. Finding the system selection, whether he used the correct system, correct file, whether it was manual, he used the same, for example, a C-shape file, a C file, or a normal K file or H file. All of this answers of why this could have happened. So in such case, it was cleaned and shaped. We reached the apical part. We were able to clean the whole canal, and this was the outcome. The lower second premolar was a hopeless tooth clinically, and this and had to be directed for extraction. Another case on the upper first molar, sorry. So we see that upper first molar had a very faint mesial canal obturation, had a distal canal also again very faint, and then the palatal canal didn't reach the apex, most probably with the accessibility, with the canal, with the glide path, all of these reasons that made these tooth to fail. But again, when cleaned and shaped correctly, it will get the job done and will have a good outcome. And then the last one was this first premolar. We can see that the tooth was underprepared, and most probably was the reason for that was again the glide path. And I was keen to bring you all the three cases, mainly concentrating about the glide path, to tell you how important is the glide path. If we don't have a good glide path, the whole treatment will be not adequate, not good enough, and will eventually reach to failure. All three cases, system didn't match the anatomy that was supposed to match. All three failures were predictable in retrospect. We can predict that these teeth can be a little bit harder. We can adjust in our system anatomy system choice in order to decrease the amount of failure. Common factor, that absence of an adaptive flexible shaping sequence, that was definitely one of the reasons why those cases failed. Just going into summary for the causes of endodontic failure, again, 45 to 50% was missed anatomy, 20 to 25% glide path related failures, and then 10 to 15% shaping related failures. So it's very important to know your anatomy, to plan for it, choose your system correctly, start with a good glide path, and then continue with a good system for shape cleaning and shaping. Here, I just wanted to summarize for you the problems and how, if we have an ideal system, ideal rotary system, what we could expect in order to overcome those problems. So for the ledge formation, we need a system that offers a flexible enough to follow the curvatures passively and never force the canal wall. In order to prevent canal transportation, we need the file that has a good center shaping and canal centering ability that preserves the original canal axis at every level of the tooth, from apical to coronal. The file separation incidence, we need a good alloy, such as heat-treated CM wires that resist both mechanical and cyclic fatigue. And as we discussed, it's not just one reason. We need to be doing good irrigation. We need to have a system that has a good debris extrusion ability so that it doesn't pack and it doesn't cause failure. Under or over preparation, we need a system that's defined sequence with an objective anatomy-driven endpoint. Some system, like this suction ability that takes your file in. So most of the time, people get to have over-prepared tools. So all of this, we need to have a good system with a defined sequence and an ease of work with to be able to decrease the amount of under or over preparation. The glide path neglects a dedicated glide path file built into the sequence, not an optional. This will let me start using the glide path file more often if it's in between the sequence of the file, and ensuring that I use a glide path file at every case. Debris packing, again, as we discussed in a little bit, coronal debris removal engineered into the file design, not just left to chance. And then sodium hypochlorite degradation, as we discussed, that we need a good metallurgy, specifically resistant to chemical surface attack that happen over the file. So all of this is how an ideal system will look like in order to overcome such problems. And this is where we reach the area where, what if our system was designed to respond to anatomy, not to fight it? Here, we start talking about the Rising system. Rising system by Fanta is one of the systems that was introduced lately, and it's here to start to discuss those problems. So one of the most important things it introduced is that this is a minimally invasive shaping file. It has a variable taper anatomical instrumentation in order to not to exert stresses over the canal wall, and to be as minimally invasive as possible in order to preserve as much tooth structure and much dentine, especially at the cervical area, in order to decrease the probability of fracture or probability of cracks that happen in the root. It makes the cone fit perfectly, as it has an apical part specifically designed at apically. The apical geometry is significantly engineered to create a reliable and reproducible apical stop for cone seating. Again, this, if we use it in a correct way, it will see significantly that it eases our life in such area. For the canal fitting, the GP fitting is going to be extremely smooth and easy. It has extreme cutting efficiency, specialized cutting angles that has never done before. So they created a new cutting angle in order to have better cutting efficiency. Maximum debris removal, again with the angles. If I have good cutting angles, I'm able to create a good geometry in the file to be able to extrude the debris coronally in easy way, not to pack and not to cause all the problems that we discussed in a little bit. Different line type phases in every file. So one of the main points in such cases, in such system, is that every file is designed specifically for the work it has with a different metallurgy. So it's not that we got one system, one alloy for all the 4 files of the system, and we said this will work for all. No, but actually every file has a different design and different metallurgy, so that it really introduce and really get the work done for such a specific part. So talking about the alloy, I know I just said that every file has a different alloy, but one of the biggest advantages of this file is that normally we had the normal 𝗏𝗏 file, 𝗏𝗏 alloy, which was always rigid, high stiff, and low flexibility. And usually this you could find it as the very silver metal looking file. And then we went into a better alloy, which was called AFL, which was flexible, improved flexibility. And later on, the AFR was introduced, and then the AFH was introduced. All of this are different alloys that was introduced in making the alloy more designed to resist the canal problems and to offer better solutions. And then now we have a new perfectly introduced alloy, which is called 𝗏𝗏𝗃 technology, which has the ultimate flexibility and superior adaptability and patient comfort for the file. If we talk about the alloy, we can go hours talking about the different austenite and martensite, different phases of the file of the alloy, and how this changing in the R phase, how changing between both states will create a good file. But again, the ProWire technology is the technology that was introduced in Rising, and it's really doing a great job in such cases. And again, to specify that different 𝗏𝗏 phase in every stage, specific metallurgy in every file, this is one of the big keys in such system. And to be honest, this wasn't done in a lot of cases. This wasn't done in most of the system that was introduced in the market. It was never done that each file has a different metallurgy. The second most important thing about the Rising, and again, specifically for the Rising, because it wasn't famous in the market, is that the same file has three different cross sections. Those three different cross sections, one in the coronal, one in the middle, one in the apical, again, answers the canal problems. So I know that, for example, I need an S shape in the apical side to be more flexible and more better cutting efficiency. And I need, for example, triangular in the coronal side to have more trunk, not to fracture. So again, having three different cross sections in the same file is one of the key points of Rising, as it really improved the flexibility of the file and the cutting efficiency. And again, we have a variable taper, as I discussed in a little bit. Every section of the file has a different variable taper. It doesn't go from head to toe, from tip till shank, for example, 6%, but it has different variable taper. Some areas are 6, some areas are 5. It goes back and forth, and this will create the good amount of flexibility with preserving as much as possible metal part to decrease the fracture ability of the file. One good thing about the Rising is that now we have literature published talking about this system. So when we have literature, the literature was peer-reviewed in good journals, and this qualifies the file and qualifies the system to make sure that it's going into the right direction. So the first study, we're going to be talking about two studies. The first study we're going to be talking now is the Beyond the Curve study, where they got 60 standardized resin blocks with 45-degree curvature. And then they had two groups. One was ProTaper Ultimate, then Supply, and the second group was Fanta Rising by Fanta. And then within those two groups, they divided into three subgroups, where they had first cycle of fuse and sterilization, and then second cycle, and then third cycle. So they used the file into three different cycles after the sterilization. And they were measuring few things. One of the things was the canal centering ability and transportation ability of every file at different levels, like at 5 reference levels. And they used to look at file deformation and separation when they were assessed under stereo microscope in order to look at the probability of separation and fracture. First result, canal centering ability, the AFR Fanta Rising won significantly, as it had a good better centric ability at every reference point, and kept doing so even after repeated serialization, which we all know that it affects the file material and affect the file work later on after sterilization. Apical transportation, again, the Rising dramatically had a lower percentage of apical transportation, which gave it an edge over the 𝗦𝗵𝗺𝗃𝗏. And for the file separation and deformation, not a single file separated across the 30 instruments and 3 sterilization cycle that happened for the Rising. And from a clinician point of view, and talking with all the KOLs, key opinion leaders who tried this Rising file, the most thing that we all agree upon is that it was very resistant to fracture, and most of us didn't even have a chance to see that the file got separated at some point, which is a very good edge for such a file. Then we look for the second paper, which was the role of temperature on cyclic fatigue resistance of thermally treated NiTi files. This is where we got 60 instruments, 30 of them were Fanta Rising 2504, and then 30 were 𝗙𝗵𝗃𝗃𝗃𝗃. They were tested at room temperature and at body temperature, so 20 degrees Celsius and 37 degrees Celsius. And we used custom stainless steel artificial canals with a 60% or 60 degrees angle curvature and 5 millimeter radius to see the amount of time to fracture. So we measure the time to fracture, the amount of time that will be used in order for a file to fracture, and then the number of cycles to fracture, which is the number of cycles that the file had to go in order to have a separated file. Rising lasted 5 times longer before fracture than the race EVO, and then the number of cycle difference was extremely different, with a statistical significance saying that Rising was very resistant to separation and was very resistant to had a way higher number of cycles in order to reach to the separation part. So just a conclusion for the Rising. Rising centered the canal better, transported the apex less, not a single file separated even after 3 sterilization cycles. When tested against race EVO, Rising survived 87 times more rotational cycle before fracturing, and its performance in the mouse is identical to its performance in the lab, as when it was tested between the body temperature and the lab temperature, there were no significant difference between the two different temperatures. So the sequence of the Rising is simple and easy. We have the RR file, which is a 10% file, orifice opener. It's used for pre-flaring, removal of the pulpal tissue at the pre-flaring part, semi-active tip, and also it's very good in removing the GPs and the retreatment. And then we have the R1 file, which is the pass file, again, as we said, integrated within the system to be used as a pass file in order to not to skip this part, as it's a very important part. This file is size 13, 3%. It has a gold specific wire, very soft and flexible. And the best thing about it is that it can be pre-bent to mimic the manual file in order to have the smooth entering into the canal and later on securing a good glide path for the file. And then we have the shaping sequence. We have the R2, R3, R4, different 2504, 3004, and then 2805, which is usually, we know that the green is usually 35 measurement at size, but again, here it's different because we decrease the size of the tip, but then increase the paper, which offered a different structure for the work. And actually, this file is usually more flexible than the R3 because of its alloy. So depending on the case, sometimes we use the R3 first, and sometimes we use the R4 first. And this is where I'm going to show you now. The protocol is simple and easy. I don't want to lose your time in the protocol, but if you look at it at the website or anything, you'll easily find it. For the easy canals, you can just go orifice opener, manual file, and then you go directly to the shaper R2 and R4 to finalize. medium canal, orifice opener, manual filing, and then use the glide path, which is very important, and then go to the R2 directly. Moderate canals, this is where you have curvatures, molars, moderate canal anatomies. Use again the first three files as used before, and then use the R2 file and then R3 file. Later on, use in the hard cases, you can use the R3 and then R4, but in the very extreme cases with 90 degrees curvatures, the manufacturer is recommending that you use the R2, R4, and then R3 in order to reach to the 30 lens easier. Let me show you a couple of cases to show you how it affected. You can see here that it has this upper second molar, had carious lesion. After cleaning and shaping, we started, it's a long roots, it has a curvature at the apical part, S-shaped curvature, and it's very long root. So I chose to use this file in the Rising system and to be able to reach the apex. And you can see that it went smoothly in this side. It's very clear and clean up to the apex. Another case, we can see this second molar again, upper right second molar. We can see that it has curvature in the root. You can see that the whole root is going into distal curvature. So we wanted to have a good file system that can allow this management of such anatomy. We started with cleaning and shaping. You can see that after cleaning and shaping, how the orifice looks small, but neat, clean, and everything's done in the correct way. We can see master cone fitting and obturation. And at the very end, we can see the curvature, how it's from the middle third of the root, how it's curved, and how it was able to be managed. Lastly, we can see this very small video about management of the lower eight. I made sure to get to the hard lower eight case, specifically this one, as the patient was traveling in the same day. So there was literally very low time to be able to do lots build up or anything, and the patient was agreeing 100% to follow this case. So we decided by isolation, access opening. Yes, definitely it's better to do a build up before starting. But again, sometimes because of patient, we have to adapt a little bit to offer better way. But I wanted to show you this case that in lower wisdom teeth, sometimes it's very hard to access and introduce our files. So we have to introduce a very reliable system to make sure that it doesn't break. And you can see it like the tongue, like the sheets, how it's a little bit hard to introduce everything. Again, we went for the R2 file, continued for the 2504, and you see the cleaning after cleaning and shaping, how the canals are going in a nice way. R3 file, and then R4 file. This is the 2805% as we discussed. Irrigation. And show you now ultrasonic activation, which is very, very, very important in all cases. I'd never end the case without using it. GP fitting. We can see the GP master cone fit and using bioceramic sealer, injecting the bioceramic and sealer inside the canal, GP cutting with system B. And we can see here how the curves were treated nicely and how the tooth was managed in a single visit approach and in an easy way. So just to sum up, 5 principles for safe and successful root canal preparation. Assess first. This is a take away home message, please, if you have time. take a photo of this slide. It's very important to always look at it, maybe print it, have it over your wall. Assess first, radiograph 𝗙𝗍 when indicated curvature mapping. Look at the tooth, understand what you're going in. Take a quality radiograph, use 𝗙𝗍 if anatomy is complex or unclear, map canal curvature, angle, radius, length, all of this. It matters very much, as why understanding the anatomy upfront help prevent procedural errors and the choice of a good system that will work significantly in a good way with you. Sorry. And then the glide pass always is an important step. No rotary before clear pass exists. Again, a glide pass reduces the risk of ledging, transportation, and instrument separation. Match system to anatomy. Curvature drives file selection. So with the bigger the curvature is, or the more steep angle it is, then choose a system that allows this to improve safety and efficacy and outcomes. Respect feedback. Resistance means stop and reassess. If you find resistance with the file, stop, go back to your manual files. We always say it, in doubt, hands file out. So when you have any doubt of the canal, just get your manual files, go back to your tactile sensation, sense the canal, and follow your knowledge. Confirm at every step, patency, working lens, debris irrigation, use irrigation, activation. Ongoing verification at every step ensures accuracy, cleanliness, and long-term success. So plan, prepare, progress. A simple and easy way to sum up all of this. And again, I tell you that the canal doesn't care about your technique. It only responds to your system. So no, the canal doesn't really care about how you your intentions of cleaning. If you introduce the wrong system, or you take the wrong sequence, or you choose the wrong metallurgy, wrong cross section, it will only respond to this. So please have the knowledge, try to approach it in a good way and understanding, and you will decrease the amount of failures that you will face, and it will be easier for you. Thank you very much. My name is Dr. Samer Hanna. Please, here's the QR code for my contacts. You can reach out to me if you have any questions. And Amy, I'm happy to listen to if you have any questions about, or if any of the attendees had a question.
Yes, thank you, Dr. Samia. And there is one question in the comment section, says that how about using EDTA solution or gel in the blocked canals?
Okay, that's a very good question, and we didn't talk about it today, but EDTA is a very essential tool, especially in blocked canals. So I always say we use the EDTA gel, which is the cream form, into negotiating the canals. So at the very start, if I cannot reach my glide path in a correct way, I introduce the EDTA gel. It helps me with the dentine debris. It helps me with the lubrication, and it will make my file reach to the apical subpart. However, if you are using the EDTA gel, don't use with it any rotary instrument, because with the rotation and the viscosity of the gel or the cream and the debris, it will increase the clogging over the file and will increase the level of tension over the file. So again, just to sum up, use the gel and the cream with the manual file. Pre-bend your file, use it up until you reach a good glide path. And then when you're working with your rotary instrument, don't use the cream one. Use just the sodium hypochlorite, and then use the liquid EDTA gel, liquid EDTA at the very end in order to clean the smear layer as indicated in the irrigation protocols. I hope this answers your question.
Thank you. Thank you so much for giving us the wonderful course. And thank you all, and looking forward to your next participation. If you have any question further, you can direct message to Dr. Samia, and also you can send to us. Thank you.
Thank you very much, Amy. Thank you very much, everyone who attended, and we'll be waiting to hear from you. Thank you.
Thank you.